So this last section of neurology is going to focus on the central nervous system. And just remember that is comprised of both the brain and the spinal cord. That's the only thing that we're talking about here is the yellow and the green. Those peripheral nerves are not included. So when we talk about mapping the brain or the components of the brain or regions of the brain, if you will, we're talking about the cerebrum, which is the two big hemispheres that we very easily see. There's a diencephalon that kind of sits inside, and then you have the brainstem, which is kind of up underneath that diencephalon. And then you also have, I always refer to it as the hair bun, because it looks like a little woman's hair bun from like when they were in the old westerns and stuff. But it's the cerebellum, and it sits at the back in the base of the brain. Now, both hemispheres share control over some functions, including motor control, sensory, vision, hearing, and memory, and all of those take place in different regions of the cerebrum. Now, the diencephalon is comprised of both the thalamus and the hypothalamus. And your thalamus is really your processing data, your center for your sensory data. Your hypothalamus is really closely connected in with the pituitary gland. And the pituitary gland is like your master control center for the endocrine system. So it's kind of like, if you think about it, that's how you're connecting the decisions between the nervous system, that electrical component, versus when the chemical component should kick in. So that pituitary gland control centers for the endocrine system. That's the connection between the hypothalamus and the pituitary gland together. You also have the ability here to modulate pain and temperature. That takes place between the thalamus and the hypothalamus. Now, the limbic system is considered part of our old reptilian brain. It's located near the diencephalon, and it controls our emotional responses. So, in addition to controlling those emotional responses, it can modify the way we act and how we respond to fear or, anything like that. The limbic system is thought to guide a person by creating emotional responses that increase the chances of survival. So that's how the limbic system is all about that older reptilian brain. And when we talk about a reptilian brain, you think about a reptile, a snake, for example. Snakes either are eating or doing their thing, or they're trying to protect themselves, so they'll bite you to try to get you to leave them alone. And it's how the limbic system is that part of our brain that decides how we're going to respond to the environment and gives us that gives us the best chance for survival. So it's that oldest part of our brain that really is centered on making sure that we stay alive. It's all about survival here. So if you've ever seen someone who went from having a debate or a discussion with someone and it turns really nasty and all of a sudden they're screaming and yelling at each other, the limbic system has turned around and kind of kicked in, and it's trying to interpret and behave that way as a result of that. Now you also have the brainstem, and this is where it extends from the base of the brain to the spinal cord. It consists of three parts. You have the medulla, the pons, and the midbrain. So this is the medulla, the pons, and the midbrain. And these are your control centers for respiration. It's that involuntary control. We can't control that. You have heart rate, and then you have blood vessel function. Now, you may be thinking to yourself, well, I can hold my breath. Yes, you can. That is a separate process. If you've ever had a child that's looked into you and said, I'm going to hold my breath till I die, and they hold their breath, and if they can actually make it that far, they pass out. That involuntary, that control center has said, okay, we need to reboot you because you're being silly. And so it kind of takes over. Now the cerebellum, that's that little portion on the bottom and the back. It is responsible for the unconscious control of the somatic motor activity. So remember, this is about skeletal muscles. When we talk about somatic motor activity, skeletal muscle. So it gives us our balance and coordination. It integrates that sensory information concerning posture or position and coordinates our skeletal muscle responses. So if you ever have someone that has a head injury and they've had that coup contra coup and they've had damage or pressure that has been placed on that cerebellum, they may have to learn how to walk again because they've lost um, that motor response. They have to retrain themselves. Now, the hemispheres of the cerebrum, these are divided into lobes. Of course, you have the frontal lobe, parietal, which is kind of in the center. I'll try to line these out here. So you got the frontal lobe, you have the parietal, and then you have the temporal, which is right here. And I think about that being at the temple. So if you think about your temple region, that's about where your temporal is. And then you have the occipital, which is the back. And each hemisphere also has its own ventricle that allows cerebral spinal fluid to be circulated through and keep everything bathed. Now, this just gives you a quick rundown of the different processes that take place here. I'm going to highlight the main ones for you, and I'm hoping it comes through in the video presentation. But you need to understand speech using words that takes place there at that parietal lobe. The occipital involves your vision. You can see things. So if they take a hit to the back of the head, it can impact their ability to see. So that is important for the occipital. You have interpretations of sensory experiences of visual and auditory information that takes place in the temporal region. And there's your hearing, so it's right there again in your temporal. And then you have problem solving, concentration, planning. All of that is taking place up here in the frontal lobe. So those are the big things that we need to recall. Now you have this piece that's called the corpus callosum, and it is the guy that kind of hangs in the middle between those two hemispheres and forces them to talk to each other. So this next slide shows you a pretty good picture of what that looks like in real life. That is what the corpus callosum looks like. It kind of holds everything together, puts those two hemispheres together. And we do need to spend a few minutes and look at the protective structures of the brain. And when we talk about that, we're talking about the meninges. And this picture does a pretty good job, and we're going to look at each individual piece and part. But you have the dura mater, you have an arachnoid layer, and then you have a pia mater. And pia mater is considered your basement membrane. It comes in direct contact with the brain. We're going to look at each of those. So you have the dura mater, that is your outermost layer. You have the arachnoid layer, that is your middle layer. And then you have the pia mater, and this is your innermost layer. It's the basement membrane. So here's another picture to show you what this looks like. So you have the skull, and then you have the dura. Now, if it's between the skull and the dura, and it's sitting on top of the dura, what do you think it's called? It's called the epidura. So if you have an epidural bleed, then you have a bleed that's occurring in the space between the skull and the dura mater, so it's epidural. And if it's below the dura, it's subdural. So you have your subdural layer. And then below that, you have the arachnoid. So I think about spiders, and if you look at this, this looks pretty spidery to me. So you have the arachnoid, and then below that, you have the subarachnoid. And then beneath that, you have the basement membrane that comes in contact with the brain tissue, and that's called the pia mater. Just a good picture to kind of show you how those ventricles appear. Remember, they are responsible for circulating that cerebral spinal fluid. Now we're going to look at the spinal cord. Spinal cord has the same types of protectors here. So if you look, you have the dura mater, you have the arachnoid, you can kind of see it better over here, I think, and then you have the pia mater. And just like with that, you have the epidural, subdural, arachnoid, subarachnoid, and pia. And if you ever want to gross yourself out and make yourself not want to eat a chicken again, go to your deli and pick up a chicken that's been rotisseried. Um, Open up the back where you can kind of look in and peer in at the spine. You will see these little bundles come together off the spinal cord. So you'll be able to see those little root bundles in the ganglia. So it kind of shows you what that looks like. And this is just to kind of give you some concept of the way that spinal cord appears. You have the cervical space that has this little tiny appearance. Thoracic is a lot larger because it's a little bit more stable area. You got lots of bone to kind of hold it together. The lumbar is our main weight-bearing region. You've got this larger part of the spinal cord here. And then as you start ducking down, remember I told you turn into the cauda equina, and that's called the horse's tail. That cauda equina is the point at which it kind of, you leave the point of being the actual spinal cord, and you start branching out. So it's like a bundle. And remember, don't forget, you've got 8 cranial nerves in comparison, or cranial, I'm sorry, 8 cervical nerves in comparison to the amount of vertebrae. Remember, you got 7 cervical vertebrae, but you have a total of 8 cervical nerves. Still have the same number of thoracic nerves. You have 12 thoracic nerves, 5 lumbar nerves, and you have 5 sacral and 1 coccygeal. You do have these things called dermatomes, and dermatomes can tell you a lot about if your patient is having problems discerning sensory information that's coming up the system. So if you have someone that has had a traumatic injury, maybe they hurt their back in some way, and they tell you they can't feel their pinky, for example, then you know if they can't feel their pinky or it's tingling, then that tells you that there's been damage to the cervical 8 nerve, so C8 nerve. So this kind of gives you an idea of where the damage is coming from. Now there's 2 primary dermatomes that you need to know. Okay, you need to know T4. T4 is nipple line. And you need to know T10. T10 is umbilical. So when they start talking about giving epidurals to women that are in labor, they will lose sensation from T10 down because you're impacting that T10 nerve that sits at the belly button. But those are the 2 that most often get correlated on exams, is T4 and T10. So it's really good if you know that that patient is telling you that they don't have any sensation at all in their thumb, then you need to relate that information onto your patient care report and tell the receiving facility, because that's going to help them locate where the damage has occurred, or what nerve has been impinged. So again, just another, I think this is a nice picture because it gives you an idea of what this looks like. Same thing with the lower limbs. And we also should talk about the reflex arc. Remember, I told you in one of the earlier presentations, you have those interneurons that will connect that sensory nerve to the motor nerve. So that is what we're looking at here with the reflex arc. So it's a real quick way for your body to fix it when it notices that there's a problem. It doesn't have to go to the brain for conscious processing. The spinal cord says, I can handle it. Go fix yourself. And it'll tell you to move off of that tack. That's a reflex arc because it's a direct connection. Now, if you've ever had someone use the reflex hammer on your knee, they're trying to assess your response to a muscle being stretched. So when that hammer comes in and hits, it's hitting on a tendon. And that tendon, because you're pushing on it, actually forces that quadricep muscle to push down, right? And as a result of that pull or that tension that occurs on the quadricep muscle, that sensory nerve recognizes that and says, well, wait a minute, what's going on? Sends that information up and says, how do we fix this? Then it sends the signal down and says, okay, we need to return to normal, so we're going to kick the leg out and we're going to see how good that response is. Again, that's about that reflex arc. We're trying to see how well our body responds to a stimulus. We're wanting to make sure that the problem is the problem with the sensory neuron side or is the problem with the motor neuron side. Where does the problem exist? And they're just testing that out. We're going to briefly cover general census, so let's just take a quick look at this. And if you want, you can go ahead and pause the slide where you need to. But we look at our special senses. So we're talking about our sense of sight, our sense of smell, hearing, taste. Those are all of our special senses. But there's a few slides that, or a few slides that we're going to look at that specifically look at other components of the special senses we really don't take into account. These include your pain receptors. So pain receptors are also known, the big fancy word for it, because you can't just call it pain receptors, is nociceptors. So you can have two different types of pain. You can have fast pain, which is a very sharp, it's localized, it's very easy to identify. Or you could have slow pain because it's more of an aching, burning sensation. And we can't hit this without talking about referred pain. And as you progress through the program, you're going to find how those referred pains correlate in. So, we always talk about the heart and the heart having that referred pain, or maybe they have pain in the left side that goes up into the neck or into the jaw, or maybe it travels down the length of the arm. That would be considered a referred pain. We're going to look at each of those and kind of explain those as we move forward. But referred pain is something that we do need to take into account as paramedics. Now you can have thermo and mechanoreceptors. Now thermoreceptors, guess what they're interpreting? They're interpreting temperature. Mechanoreceptors, on the other hand, are interpreting mechanical. So they're looking at touch and pressure. They're looking at different things. You can have a receptor that's really close to the skin, which is what you see here. Those are the ones that sensory nerve can identify if you have a fly land on you and it just slowly kind of bounces across your skin. That one that is right there is the one that's going to interpret it. That deeper sensory nerve, that little dendrite right there, is not going to recognize that because it requires that deeper pressure, that push down further into the tissue for it to recognize or acknowledge what's going on. And then you have another one called proprioception. And proprioception is about you being able to interpret your body within the environment that you're in. So it's trying to receive information about where you're at. That's proprioception. It kind of helps you with your balance and your sense of where your body positioning is in the world around you. And then another one that we talk about is our chemo and baroreceptors. So chemoreceptors measure chemical. It's all about your blood pH. Your baroreceptors are about stretch. And I think one of the best baroreceptors we could talk about is your bladder, because if you've been sitting for too long, suddenly you have to go to the bathroom, you have that receptor that is now being stretched because the bladder is so full that it's triggering that baroreceptors, recognizing that there's pressure, and it's telling your brain you need to go to the bathroom. So chemical for chemoreceptors, we're looking at blood pH. Baroreceptors measure pressure. So we start talking about a full bladder will be an example of that. It's recognizing that there's added pressure and you need to do something about it. So we do want to kind of look at the disorders of the nervous system. And the first one that we want to look at is the coup contra coup. So the coup is the initial force, And then because that brain kind of bounces backwards, that would be a contra coup because it's moving away from the impact. So that's a coup contra coup. And the problem with the brain tissue is if it bounces around in there, not only is it bouncing and hitting those sides, but you have some shearing sensation that can cause tearing and tissue damage to the brain tissue itself. So coup and contra coup. Now this is where we kind of start talking about epidural and subdural bleeds. We kind of dig into these a lot more when we get into trauma, so you'll actually get to see some x-rays with some subdural and epidural hemorrhages, and you'll be able to identify them. They're actually really easy to identify as long as you know what you're looking for. So an epidural bleed, anytime, what I want you to know right now, anytime you hear epidural, I want you to think that is a fast arterial bleed. Epidural bleed is a fast arterial bleed. Subdurals are venous. Epidural arterial, subdural venous. For National Registry, when it comes to trauma, the head trauma that results in epidural bleed, that arterial bleed, is going to be coming from the temporal region, and the artery that's impacted is the middle meningeal artery. So middle meningeal artery, usually the temporal region. So they'll give you a scenario. They'll tell you that a kid's playing baseball and he takes a line drive hit to the temporal region and he has an immediate loss of consciousness. He has an immediate loss of consciousness because it's arterial. It's an arterial bleed, so it's going to be a fast bleed. Arteries bleed heavy. Or you can have that flip side. You can have that guy, the local town drunk. He's the town drunk. You get called out to him 20 times a day or 20 times a week, whatever. He's out drinking every night, so he stumbles and staggers around. And he, because he has bad balance from all the alcohol he's consumed, he could have fell, and as a result of the fall, he could have caused a bleed internally. That is more likely to be a venous subdural bleed because it's a slower bleed. And if it's a slower bleed, it takes longer for it to come on. And then you can also have subarachnoid bleeds, and those are kind of hemorrhages that occur below the level of the arachnoid space. So you can kind of imagine where that takes place in the dura mater. And those have a different, more diffuse presentation. And we'll see it more on an x-ray. This picture doesn't do what actually you will see. It doesn't do justice. So we'll get there. Now with memory, you have two classes of memory. You have short-term and long-term memory. Short-term memory is your primary memories can be recalled for a very short period of time, then we'll lose them. Hopefully we're not having this issue with medic class. You want to take all of this short-term data I'm giving you and you want to stick it to the long-term memory because you want to be able to retain it for an extended period of time. You have a case of amnesia that may happen as a loss. I'm sorry, my spelling was terrible. I was trying to type it out. Loss of memory from disease or trauma. The types of memory loss depend on the specific region that's involved. And there's two different types of amnesia that we talk about as paramedics. Now there's two types of amnesia. You have retrograde and antegrade amnesia that you will see as paramedics. So if you've ever been out on that trauma call, that motor vehicle collision, whatever it was, and you had that patient, they looked at you and they said, I have no idea what happened. That's considered retrograde amnesia because they don't remember what happened prior to the incident. Okay? That makes sense, right? They don't remember what happened in the past, retro. They don't remember what happened before the injury. Then you have a condition that's called antegrade amnesia. If you've ever had the patient in the back of your truck and they say, what happened? And you say, you wrecked your truck. And they go, oh, okay. And then 5 minutes later, they ask you, what happened? You wrecked your truck. Oh, okay. And then 5 minutes later, he said, what happened? You wrecked your truck. Okay. They're not recalling the information that's being given to them after the incident occurred. So that's antegrade amnesia. as you are aware, you know that you have different types of cerebral vascular accidents. It can be, um, in most cases, your your strokes are the result of an ischemic stroke. So you've had a blood clot that has prevented blood flow to the brain that's causing the stroke, or it could be hemorrhagic stroke. And that's what you see in this post-mortem picture on the top is the blood that has translated into the brain tissue from the bleed, the hemorrhagic bleed. You can also have a transient ischemic stroke. And in the case of a TIA, you've got a blood clot that has occluded blood flow going into the brain, so they have the same initial response like you would see with a stroke patient. But because that clot is small enough, or maybe it's your body's natural ability to break the clot down catches it quick enough, it dissolves that and allows the blood flow to pick back up. So in your TIAs, you'll have that initial impact. Your body's able to break it down and get rid of that clot, and then they'll start to regain their function. And then, of course, you also have your seizure disorders. That's another example, and we're going to go really deep into seizure disorders when we get there. You can have penetrating trauma, and you can have infections that impact the nervous system, specifically meningitis. Meningitis and encephalitis present very similar, but National Registry will always go toward meningitis. So just expect meningitis on your test. You will hardly ever see encephalitis come up. But meningitis can be viral. It can have, there's unusual forms of meningitis that can occur, but they are out there. You can have a parasitic brain infection or a brain abscess, which is what you're seeing here in the bottom. You're seeing this nasty pus within the brain tissue. And then, of course, you've got encephalitis. And with headaches, sometimes National Registry likes to pick on headaches. So you have different types of headaches. Migraines, and there's some irony here to this picture because migraines occur more likely in women. Cluster headaches occur more often in men. Now, that's not to say that a man can't have a migraine and a woman can't have a cluster headache, but most often migraines affect women, cluster headaches affect men. The way they present is very different. Migraines, you have the intense pain in and around the eyes. They sometimes have an aura where they can see like a halo or a fuzz around items. They'll have nausea, vomiting, light sensitivity. It can impact their entire being, and they have to like completely stop everything to make it go away. That's your migraine headache. A cluster headache actually deals with the sinuses. It usually occurs around and in behind the eyeball on one specific side. You may have redness of the eye or tearing because the sinuses are irritated. But the bad thing about the cluster headaches is they can come on, so they come and go. You can have a cluster headache for a few hours, it'll go away for a while, and then it comes back. And then, of course, you have tension headaches, which are usually in the neck. And we talk a lot about the different types of trauma and the spinal cord injuries in particular. There's all kinds of categories, as you can see here. One's even called one that we want to hound on because for whatever reason National likes it, is Brown-Sequard syndrome. So when we get there, we'll kind of talk about that a little bit more. But that's one of those big ones. And of course, you have the different ways the spinal cord itself can be injured. So we'll look deeply into those as we move forward. And here is a condition that you really need to take into account. It's called autonomic dysreflexia. And it's where you have some sort of cord damage at or above T6. So remember, T4 is nipple line, so you're just a little bit above that. So damage at or above T6, and it causes a surge in sympathetic response. So let me give you a better example of this. When you have someone who has had some sort of spinal trauma that's occurred in that region, so at or above T6, and they have a full bladder. Everything that's happening at the spinal cord below the level of the damage doesn't know there's a problem. It's in feed or breed heaven because it doesn't know to do anything different. It just kind of sits there. But above that site, it's panicking, right? So you have this fight or flight response. You have a surge of the fight or flight response. Here's where it comes a thing. This is where autonomic dysreflexia comes in. If you have someone who has a full bladder, or maybe they have a lot of fecal matter in their rectum, and we know that when you have to go to the bathroom, or when you have to do number one or number two, you're going to have that baroreceptor we talked about earlier that's going to tell you, hey, I need to get up and go to the bathroom, or I'm going to be embarrassing myself really soon. The problem with someone who's had that damage at T6 or above, the information coming from those baroreceptors coming up and then trying to come down the line doesn't know how to interpret the information. It's really stinking confused. It just doesn't understand what's going on, and your body freaks out. It goes into this surge of a sympathetic response. The only way to fix those patients, this is a life-threatening situation, okay? We're talking serious life threat, autonomic dysreflexia, serious life threat. The only way to fix this is to find the offending agent and fix it. So if it's a full bladder, you need to put in a Foley catheter. If it's a full rectum, yeah, friends, you're gonna be removing that. Not fun, but that's what you've got to do. And then because this can kill them, the surge in the sympathetic response is so high it can literally kill them. So that's just kind of a side note for you, and we will definitely talk about that when we get into trauma. Then you have the Babinski reflex or the plantar reflex. So if you ran your pen up the foot of a baby because they haven't figured out their motor system is still really confused, it's really young, it doesn't know how to respond, you will have a positive Babinski reflex. You will have that plantar reflex. They will flare their feet out. That's normal. Okay? That plantar reflex in a child is normal. But if you run your pen, or they've got a little device here, they're running up the bottom of the adult's foot. The adult has been up moving, and the motor system is really sophisticated. If you have a positive Babinski, you have the flaring of the toes in an adult, that tells you that the information, that sensory information coming up, is not being interpreted and brought down correctly, because the foot should scrunch down and pull away from that pin or whatever you're using to kind of poke at them. So that is an indicator of trauma. We did talk about multiple sclerosis, and this is just a good picture for you. The body recognizes that myelin sheath is foreign, and it attacks it and starts breaking it down. Because that sheath is not protecting that electrical wire, then the impulses are not getting transmitted like they should. That is the condition called multiple sclerosis. So that's where that relays into. Now we do have amyotrophic lateral sclerosis down here, and I do realize that I've kind of got it on a weird slide because this is relating directly to multiple sclerosis. ALS is different. Remember, ALS, it's about the synaptic terminal slowly atrophying away, and it can't, that signal, that neurotransmitter can't jump the synaptic cleft anymore. So I hope this presentation has kind of helped you go back and refresh and kind of dust the cobwebs off and see how the anatomy and physiology and understanding what's normal helps you kind of relate to and identify those signs and symptoms for pathology. So we will be redigging into this. This is just a simple foundational review, and we're going to keep going back and re-discussing and re-hitting and keep building upon this. So I hope this has helped, and I hope you have a wonderful week, and we will see you next time.